Let's talk about how we are going to diagnose a patient with primary sclerosing cholangitis. The definitive diagnosis is made by the radiological test, specifically various procedures like we do, like ERCP or the MRCP, magnetic resonance cholangiography, or certain types of transhepatic cholangiograms. But there are certain lab findings which are very helpful in the first place. So when we have a patient presenting with the typical signs and symptoms suggestive of a cholestatic disorder, we first perform the labs, and if the labs are then indicative of primary sclerosing cholangitis, and if they rule out the other pathologies, then we proceed onwards with the radiological imaging. What are the important things to look for in the lab findings? The patient will have elevated serum alkaline phosphatase level, or ALP levels. Now, these ALP levels are very specific to the biliary tree. Along with the ALP levels, we also do the GGT levels. When both of these are combined, ALP can also be elevated in certain types of bone abnormalities, as we saw, for example, in patients with Paget's disease of the bone. So, to establish the fact that this elevated ALP in relation to the signs and symptoms is related to the liver or the biliary tree, we do GGT levels as well, gamma glutamyl transferase. If both the GGT and serum alkaline phosphatase are elevated, then that can specify that the patient has certain biliary pathology going on. So there will be an elevated alk phos level, ALP, and along with that, there will be an increase in the GGT level. The patient will present with jaundice, so the serum bilirubin can also be elevated. Now, liver biopsy is not performed routinely. It can be performed to rule out the other disorders, specifically if there is an inconclusive picture, like we talked about in the differential diagnosis section, that some patients with primary biliary cirrhosis or primary biliary cholangitis, they have a similar clinical presentation to the patients with primary sclerosing cholangitis, and the labs are almost the same. So if the disease is inconclusive after the laboratory procedure, then we can proceed onwards with the liver biopsy. And the liver biopsy can be performed in those patients in which we suspect malignancy. So we try to rule out the malignant potential, either cholangiocarcinoma or development of a hepatocellular carcinoma. Serum aminotransferase level will be elevated, AST or ALT, and this will be elevated in the long-standing disease. Initially, they might be normal. So as the disease progresses, if the strictures start forming and there is obstruction to the bile flow, then if AST levels or ALT levels can be elevated, and they signify an injury to the hepatocytes. This injury can be because of the obstruction of the bile flow. Serum bilirubin level will be elevated definitively, and the major component that is elevated is the direct bilirubin or the conjugated bilirubin. Serum albumin levels, this signifies the liver pathology. If the disease is long-standing and if it is not corrected and it eventually damages the hepatocytes, then the certain markers that signify the liver function, they can be abnormal as well. For example, in long-standing disease, and if the liver gets damaged and there is development of the cirrhosis, then we can have decreased albumin levels because albumin is produced by the liver. The PT time will be elevated because of the deficiency of the coagulation factor, specifically the factor 7. Now, we also perform the copper studies in these patients. This is generally performed to distinguish or this is performed to rule out Wilson's disease, which is one of the diseases that affects the liver and can lead to the development of the cirrhosis, in which there is problem with the copper flow in the bile. So to differentiate Wilson's disease from, which also has a similar presentation initially, to differentiate that disorder from primary sclerosing cholangitis, we perform certain copper studies that can include serum copper, serum ceruloplasmin. Ceruloplasmin is the protein that binds copper into the blood, and it is produced by the liver. So in patients with Wilson's disease, serum ceruloplasmin levels are generally low. So a normal ceruloplasmin eventually or basically rules out Wilson's disease. Hepatic copper levels can also be done to find out the copper levels or the copper accumulation into the liver. And finally, urinary copper excretion completes the whole profile for the Wilson's disease. The major important tests for Wilson's disease are serum ceruloplasmin, the hepatic copper levels, or the urinary copper excretion, but the definitive diagnosis is made by the liver biopsy. There can be an elevation of the serum cholesterol secondary to the obstruction of its flow. So this can also be a risk factor for coronary artery disease as well in a long-standing population. All right. Along with that, there can be certain immunological markers like serum autoantibodies. And these autoantibodies are used to distinguish the various types of disorders. For example, in patients with primary sclerosing cholangitis, we might have elevations of the serum PNK antibodies, anti-neutrophil cytoplasmic antibody. PNK. It is positive in a large majority of the population, and it can be used to distinguish primary sclerosing cholangitis from, let's say, primary biliary cholangitis or autoimmune hepatitis. In primary biliary cholangitis, anti-smooth muscle antibodies will be elevated, so this differentiates it from PSC. And in patients with autoimmune hepatitis, we might have an elevation of anti-PKLI or anti-liver cytosolic proteins or antimicrosomal antibodies. So it is important to keep in mind these various types of autoantibodies because they can be helpful in distinguishing the various disorders which present clinically in a more or less similar picture. Along with that, in patients with primary sclerosing cholangitis, we have elevations of IgM levels. Smooth muscle antibodies, ANA is very non-specific. It can be elevated in a long list of disorders, but anti-smooth muscle antibodies is basically elevated generally in primary biliary cirrhosis or primary biliary cholangitis. So that can be used to distinguish the two. And if we have a suspicion of certain types of immunological problems like the systemic lupus erythematosus, then we can do anticardiolate antibodies as well. But this is not generally performed because the picture is generally very clear, and based on the other tests which we have done, we can have a very good idea. But this is done basically to differentiate systemic lupus erythematosus from a PSC. These were the commonly performed labs in a patient presenting with. You can say that these were the labs generally which are done in a patient presenting with a cholestatic picture. For example, someone with jaundice, upper right abdominal pain, and someone on initial LFTs who has elevation of the direct bilirubin and the serum transaminase and the ALP levels. Then we can do all of these labs in a periodic fashion to rule out the various disorders. Definitive diagnosis will be made on the imaging, which we are going to talk about in the imaging section.